Good evening, friends. Myself, Dr. Maulik Parmar, MD Radio Diagnosis at SIMS Hospital. Today, we will discuss radiological investigations in COVID-19. First of all, we will discuss a multinational consensus statement from the Fleischner Society, which is the backbone guideline for the role of radiological investigation in COVID-19 pandemic. Essential points of these statements are: first, imaging is not indicated in patient with suspected COVID-19 status and mild clinical features of COVID-19 patients unless they are at risk of disease progression. Second, imaging is indicated in patient with COVID-19 and worsening of respiratory status or clinical status. In resource content environment, imaging is indicated for medical triage of patient with suspected COVID-19 features who present with moderate to severe clinical features and have high pretest probability of the disease. But sometimes they don't have PCR-RT kits or there is a delay in the test results. So in that scenario, we can try this moderate to high risk patients with CT findings. Statement focuses exclusively on the use of chest radiography and computed tomography of thorax. Ultrasound has not been much used for triage or diagnosis of these patients. Non-availability of PCR-RT kits and reported false negative results of PCR-RT makes imaging a helping tool, as we already discussed. Now, chest X-ray versus CT. Preference is mainly left to the judgment of clinical teams. And since chest X-ray is less sensitive and not suitable for screening or triage, the main focus is on CT. And in hospitalized patients, chest X-ray is mainly useful for disease progression and alternative diagnosis, such as lobar pneumonia, suggestive of bacterial superinfection, development of pneumothorax or pleural effusion. CT is obviously more sensitive for early lung parenchymal changes to detect disease progression and for alternative diagnosis and some complications that have been reported with COVID-19, such as pulmonary thromboembolism or acute heart failure due to COVID-19 virus-related myocarditis. There are some general suggestions by consensus on use of imaging, such as daily chest radiographs are not indicated in stable patients. CT is indicated only in such patients in which you suspect functional impairment and oblique or hypoxemia even after recovery from COVID-19. COVID-19 PCR-RT testing is indicated in patients whom you find incidentally typical features suggestive of COVID-19. Now we will discuss Radiological Society of North America expert consensus statement on reporting of chest CT finding related to COVID-19, which basically aims to provide a guidance to radiologists reporting CT findings which are potentially attributed to COVID-19 pneumonia. It also standardized the reporting language and such improve communication with referring providers and has the potential to enhance efficiency and aid in management thus. It is based on several papers suggesting that some findings are typical in COVID-19, some findings are overlapping features, and some are atypical and some are unlikely for COVID-19 pneumonia. It also addresses how to report incidentally discovered features potentially attributed to COVID-19 pneumonia. It also prescribes to initiate standard operating procedures in case of potential exposure to such incidental patients. Guys, I would like to remind you, if you have any questions regarding any slides, kindly put that question into chat box. We will address that later on. Now we will see categories of CT findings, that is imaging classification and rationale for those findings to be put in particular category. First of all, typical features. Typical features are the features who are frequently and more specifically seen in COVID-19 pneumonia in current pandemic. In current pandemic, these features would more suggest towards COVID-19 rather than other diagnoses such as influenza pneumonia or other causes of secondary organizing pneumonia. Indeterminate features are those features who have been reported with COVID-19 pneumonia but are not specific enough and which have been seen in variety of infectious and non-infectious causes such as hypersensitivity pneumonitis, lung congestion due to heart failure, or non-specific interstitial pneumonia, or it can be secondary opportunistic infections like CMV or PCP. Atypical features are the features who are uncommon or not commonly occurring in COVID-19 pneumonia and which are more suggestive of other diseases, particularly infections. Negative features means there are no findings in CT. This slide is most important for our discussion. Here we are seeing CT findings, the rationale of the CT findings to be put in a particular classification and suggested reporting language for those findings. The typical CT findings for COVID pneumonia are if peripheral, bilateral ground glass opacities with or without consolidation or with or without intralobular or interlobular lines, giving crazy paving appearance. Reverse halo sign or other findings of organizing pneumonia are also considered in this category. The suggested reporting language would be commonly reported imaging features of COVID-19 pneumonia are present. Other processes such as influenza pneumonia and organizing pneumonia, as can be seen with other causes, can cause a similar imaging pattern. And here, the purpose of report coding will be COVID-19 tip. If you see some indeterminate CT features in the absence of typical features as stated above, such as multifocal diffuse, perihilar or unilateral ground glass opacities with or without consolidation, lacking any specific distribution as stated above, such as peripheral distribution, lower lobar distribution, and are not rounded or non-peripheral, and very few small scattered ground glass opacities having no rounded or non-peripheral distribution. In case of such features, the imaging findings will be reported as imaging features can be seen with COVID-19 pneumonia, though are non-specific and can occur with variety of infectious and non-infectious processes. And the reporting code will be COVID-19 indeterminate. If you find atypical features such as isolated lobar or segmental consolidation without ground glass opacity, discrete small nodular opacities, you find consolidation with large cavitation, or you find smooth interlobular septal thickening with pleural effusion. Remember, ground glass opacities should not be present to call them atypical, and such imaging features will be reported as atypical or uncommonly reported for COVID-19 pneumonia. Alternative diagnosis should be considered, and the reporting code will be COVID-19 atypical. If you find no features of any pneumonia, then it will be negative, and reporting language will be no CT findings present to indicate any pneumonia. COVID-19 negative. There are some pros and cons of this standardized language. First of all, we will discuss pros. Clinician, maybe I'm suspecting COVID-19 in atypical presentation, clinical atypical presentations, and you might be the first person to raise the possibility of COVID-19. Initial RT-PCR may be negative, and you encourage repeat confirming testing after these typical CT findings if needed. Standardized reporting language improve the report quality and clarity, and hence improve the patient management. This data will be used as a backbone, as a building block for further future teaching, research, clinical quality improvement, and future management pathways. Cons of this standardized reporting system is true sensitivity and specificity of chest CT is yet to be specified. Even patient with normal CT or having atypical features may have COVID-19. Clinician may be biased with your reporting of COVID-19 and may ignore some important non-COVID related findings. Patient may be apprehensive seeing this terminology like COVID-19 or coronavirus in the report. Now we will review some key HRCT patterns relevant for COVID-19. I have put here two images, one coronal and one axial, showing ground glass opacities, predominantly lower lobe and peripheral distribution. I have put here because it is the most specific and most relevant feature. Ground glass opacities. Here you can see alveolar opacities which are not obscuring vessels, and it is predominantly peripheral in distribution. And here you can see some smooth interlobular septal thickening, which may be present or may not be present, but this opacity is not obscuring vessels. It is known as ground glass opacity. Consolidation, the opacity is more denser than ground glass opacity, causes obscuration of the vessels and shows presence of air bronchogram within. Interlobular septal thickening is the visibility of the interlobular septum outlining the secondary pulmonary lobule containing venolymphatic structure. Here you can see clear-cut secondary pulmonary lobule outlined by the interlobular septal thickening with central bronchovascular bundle. Remember, isolated interlobular septal thickening is not a typical feature of COVID-19. It must be present with ground glass opacities. Crazy paving pattern. This is a mixture of ground glass opacities and interlobular septal thickening. Here you can see alveolar opacities with non-obscuration of vessels, and you see the smooth interlobular septal thickening outline in between, giving crazy paving appearance. Vascular engorgement have been reported in the involved lung areas in patients. Here you can see dilated engorged vessels within the involved lung areas. These are the atypical findings for COVID-19 pneumonia, not commonly seen or atypical findings. Here you can see linear branching tubular, nodular deposits or opacities giving tree in bud appearance. Here you can see large consolidation with central cavitation. Here you can see anterior segmental lobar consolidation with air bronchogram. These are atypical for COVID-19. Now we'll discuss CT findings typical of COVID-19 pneumonia, and we will discuss temporal changes in CT findings based on a longitudinal study of 19 patients. First of all, ground glass opacity. This is the most common feature. Subtypes of ground glass opacity is pure ground glass opacity with intralobular septal thickening or interlobular septal thickening, or ground glass opacity with irregular lines and interfaces representing perilobular band-like consolidation, which is commonly seen in secondary organizing pneumonia. We will discuss them later on. Second most pattern is consolidation. And pure reticular opacities means subpleural fine reticulation not accompanied by ground glass opacity or any other feature. It is the least common finding, and usually it is seen in later course of the disease. And lastly, it is the mixed pattern. You can see combination of any of the above findings. Now we will discuss temporal changes in CT findings. Very few asymptomatic patients show CT abnormalities in that longitudinal study we already discussed. CT abnormalities increased quickly after the onset of the symptoms, and which peaked around 6 to 11 days of symptoms. And then they reached at the plateau and remained persistent at high levels for extent of longer duration of period. The most common CT finding during the entire and early course of the COVID-19 pneumonia was ground glass opacity alone in that study. Consolidation was the second most seen feature in first 11 days. Then mixed pattern with architectural distortion was second most predominant pattern, overriding the consolidation after day 11, that is between days 12 to 17. Now we will see an example case of that study showing temporal changes in CT findings. At day 1, the CT shows ground glass opacities scattered in right lower lobe and small patchy ground glass opacity in left lower lobe, not obscuring vessel, and it is not denser enough. A repeat CT scan at day 5 shows increased density of the involved regions, and there is some increase in extent of the findings as compared to previous study. The opacities are somewhat denser than the previous finding, and repeat CT scan at day 11 shows the extent is roughly same, but there is again increased in the density of previously seen opacities, and it seems like something is externally limiting these opacities to spread along, which again more pronounced at later on CT dated day 15, showing resorption of central ground glass densities with increase in perilobular band-like consolidation, suggesting starting of organizing pneumonia pattern. Now we'll see graphical representation of temporal changes in CT findings in that study. Here we can clearly see that before the onset of symptom, most common finding was normal CT scan, followed by ground glass opacity. You can see here the ground glass opacity is predominating and throughout the disease course, and in early disease course, that is up to 5 days. After day 5, consolidation is the second most pattern. You can see consolidation is most prominent in early course of the disease after ground glass opacities. In the later course of the disease, mixed pattern overrides consolidation and becomes second most common, and pure reticulation appears later on in the disease process. Here we can see graphical representation of different subtypes of the ground glass opacities. In asymptomatic patients, pure ground glass opacity is the only feature. As the disease progresses, ground glass opacity alone decreases with increasing features of intralobular septal thickening or interlobular septal thickening, or a mixed picture like surrounding irregular band-like lines. Here is the pie chart demonstration of the CT finding at the discharge of the patient in that study. At the discharge, you will find some CT findings, and the most common pattern will be ground glass opacity. Second most common will be mixed pattern. Third is consolidation, and rest normal. Among the ground glass opacity subtypes, pure ground glass opacity is most common, followed by ground glass opacity with irregular lines and bands, that is organizing pneumonia, and followed by other patterns. Now we can make some loose conclusion about the disease severity and prognosis based on experiences from SARS, MERS, and ongoing studies of COVID-19. Quantitative CT analysis in terms of calculation of CT severity score, volume and mass calculation of lung abnormalities are still under development, and multiple studies are going on to determine the relevance and significance. Only qualitative description of CT findings has been standardized till date. Obviously, it is leaving some communication gap regarding severity of the disease process. Usually, consolidation in ARDS pattern correlate with longer hospital stay, ICU stay, and subsequent fibrotic lung parenchymal abnormality. Development of pleural effusion and mediastinal lymphadenopathy may suggest secondary bacterial infection superimposed over COVID-19 viral pneumonia. Secondary organizing pneumonia, which is more commonly seen in post-recovery, may require steroid treatment to prevent severe fibrotic consequences. Here are some differences in pediatric patients in CT findings based on one study. CT abnormalities are less frequently evident in pediatric patients. Many patients will be having normal CT scans. Even if we find CT findings, they will be fewer in number and lesser in extent. And atypical findings like peribronchovascular distribution and bronchial wall thickening is more common rather than adult patients. Now we'll see quick revision of chest X-ray, the checklist. Ground glass opacities, consolidations, pleural effusions, pneumothorax, lines and tubes, and you have to compare with previous scans. Here is the schematic representation of that checklist. You have to check apices for the presence of pneumothorax and incidental tumor. You have to see central and peripheral lung. For to note any consolidation or ground glass opacities, you have to check pleural effusion at CP angles. You have to check the margins of domes of diaphragm. Is there any obscuration suggesting a lower loop consolidation? And you also have to check retrocardiac consolidation here. And then tubes and lines in central region where trachea and esophagus lies. Here are some examples of abnormalities seen in chest X-ray. This is lobar consolidation. This is diffuse multilobar consolidation. This is ill-defined multifocal consolidations. This is atelectasis or collapse of right upper lobe. You can see fine reticular interstitial markings here. Some pores in reticular interstitial markings. You may see reticulonodular findings, solitary pulmonary nodule, or multiple nodules such as metastasis or masses. Here is an example of a temporal CXR changes in a COVID-19 patient. At day 1, you can see near normal chest X-ray or some ill-defined opacities in lower lungs. Incidental finding of rib fracture here. At day 3, the opacities are now visible clearly in mid and lower zones bilaterally. And at day 7, you can see there is a significant increase in opacity and reticular markings in mid and lower zones. And you can see the condition of patient can be assumed based on these multiple lines and tubes. Use of ultrasound in COVID-19. There is practical significance and usefulness of thoracic USG is yet to be defined. It is helpful for detection of pleural effusion or empyema, that is usually secondary complications. Some studies say that it can demonstrate subpleural consolidation with air sonogram, but it is not specific enough, and there has been reported very much intra-observer and inter-observer variations. Describing A lines and B lines as more of academic interest rather than practical significance. There are cases which have been reported as complications of COVID-19, such as acute hemorrhagic necrotizing encephalopathy. Usually, this is seen with influenza or other viral infection. There are some reports of this complication in COVID-19. CT and MR would be helpful here, showing bilateral thalami, abnormalities in bilateral thalami, medial temporal lobes, and subinsular regions, that is limbic system, with hemorrhagic foci. You will not find anything in angiography or venography. Thank you very much.